Welcome to PharmacyToDose, the Critical Care Podcast, a partner of the ACCP Critical Care PRN and a member of the Pharmacy Podcast Network. And I'm your host, Nick Peters. And wherever you are and however you are listening, thank you. And this is the Trial of the Week, where I review a landmark trial that was published this month in medical history. And it's a great one today, folks, because one of the OG guests returns. Excited for UGA-C3 member Andrea Sikora to come back on the pod. We get to hear and review all about her critical care medicine study, the impact of pharmacists to improve patient care in the critically ill, a large multicenter analysis using meaningful metrics with the MRC-ICU Score. So, after hearing that, after reading that title, one thing I forgot to mention to Andrea is we got to create some title acronyms as we're going through here. So we will be working on that behind the scenes. But this is such a great study. For those unfamiliar, right, what is the MRC-ICU score, right? We talk about what that is. We highlight the PharmCrit study, which used this same data set. And then we talk about, of course, how you can implement this tool in your hospital, where we go from here. Every time Andrea joins, I learn something new. I can guarantee this will be the case for all here as well. It's time for the September Trial of the Week. So let's get going. Well, ladies and gentlemen, we are in for a treat today. Recurring guest, friend of the pod, Andrea Sikora comes back. Now, reminder for new listeners, those who may have forgot, Andrea is a clinical associate professor at the University of Georgia. She is a critical care clinical pharmacist at the Augusta University Medical Center, a federally funded researcher. She is a published author. That's right. You can go to Amazon right now, and her book, Pay It Forward, A Map to Mentorship in Medicine. So kind of like a one-liner, a warm welcome to the power of mentorship in a healthcare career. And at Andrea Sikora, and you would see all kinds of tips, clips, tricks, all the things from mentorship, advice, research. Andrea, I hope I did your intro justice. Welcome back. How are you?
I'm happy to be here. Thank you so much for that wonderful welcome, Nick.
Now, so excited to review our September Trial of the Week and get into a study and a tool that is certainly near and dear to your heart. So at the core of this featured article today is the medication regimen complexity ICU scoring tool, or as will likely probably be referred to it as the MRC-ICU. So explain to the listeners, if this, for those who this may be a new concept, what exactly is this scoring tool? Go into a little bit of the history for us.
Yes. So back in the day, when I was first starting off as an ICU pharmacist, there was a conversation about whether or not we needed a second medical ICU pharmacist versus if the surgical and CT ICU should be split up into multiple rounding teams and so forth. And there was this conversation that was all about the SOFA score and Apache score and number of orders verified. And I was like, okay, so therefore the MICU needs two pharmacists. And although I agreed with the concept, I actually agreed that the MICU did need two pharmacists, I just kept thinking about the fact that there's so much more to life than how sick a patient is. As much as we are in critical care and we think that, the sickest patients are the most interesting, our ambulatory care pharmacist friends are doing really great work and their patients do not have a SOFA score to talk about. Same with cardiology, oncology, everyone else, right? And so I started to think about what is it that makes a critical care pharmacist? What are we really doing? And this kind of gets into cognitive services of what is it that, we're really bringing to this team that goes above and beyond anyone else that could be in this scenario. And so we did a literature search and we found that there's actually a medication regimen complexity index, MRC-I, that was made for the community pharmacist. And I thought, what a neat idea. I wonder if we could adapt that to the ICU. So I added two letters, which is CU, to be ICU. And we developed this tool that is basically 38 line items. So it has things like analgesia, sedation, antibiotics, and you get points for each of them. So if you're on vancomycin, you get 3 points. If you're on a pressor, you get 2 points. If you, and so forth. And so at the end of the point, you have a sum of that, so 3 plus 2 plus 1, and then that patient has that score. And the goal with that was to be quantitative and objective and reproducible. So I could say today I took care of 10 patients with an average MRC score of 15. And you could say, oh, cool, I took care of 20 patients and the average score was 10. And we could have that conversation and know exactly what we're talking about.
And if you're curious, right, we're going to talk more about the article, but in that supplemental digital content, that first table in the Word document is a visual of the actual scoring tool. So you can see all those line items. You can see what's weighted a little bit more and not. And we'll probably get into a little bit of it. But just for those visual learners or want to keep track at home, something to kind of point out there. How cool of a concept this came out from things those are common questions, right? Those aren't like uncommon scenarios when the pharmacy department, right? The critical care team has worked so hard. We finally justified that FTE. And now you almost feel like it's Dark Knight at the end where they break a pool stick and they throw it in. And it's like, all right, well, the last one surviving gets the other pharmacist. So a really cool way to truly have like data to help support it, right? And coming from something that actually happened is awesome. So where has this like scoring tool like actually been implemented?
Yeah. So I would also say, to point to the supplemental index, there is a table that has the tool itself, and there's also a table that has a summary of every study that the MRC-ICU has been a part of up until the point of publication. So there's a few that are after that. But if you're interested in looking at the evolution of the score and the kind of the very stepwise and thoughtful process that went through we did internal validation, external validation, retest. I learned a lot about different score validation processes within this. But the first place to implement the MRC-ICU was actually Oregon Health Sciences University. Wonderful shout out to FCCM. I had, her name is Sandy Rowe. She came up and she goes, I just love this and I would love to talk to you about it. And another friend of the pod happened to be a resident at the time, Andy Webb, got roped into this. So if you go check out that paper with OHSU, it has Sandy and Andy on it both, who helped to get the score built into the system. And at the time, the concept behind it that they were interested in is there was, COVID was raging at that point. We're dealing with patient surges, staffing shortages, everything else. And what they wanted was a way to help, in case we needed non-ICU pharmacists to be able to support the ICU pharmacy staff because of these surges. Was there a way that you could say, hey, look at this patient first? And then from there, the critical care pharmacist also kind of incorporated into a prioritization system. So we have that paper out, and actually another one that just got accepted to Jemiah Open about that story.
And I love that you pointed out the studies, right? Table 2 right below it. And then to make lives just easier for everybody, beautiful reference list right after listing them all. So, we'll touch on a few of them, but if you're curious, you want to learn more, very, very, literally almost as easy as you can make it other than truly just emailing the article to everybody. Now, looking at these past studies, right? And it looks like, if I'm counting right, about 11 of them. What kind of, from an overview type of perspective, what type of studies were these as we get into our trial of the week study? Kind of lay the foundation for what kind of evidence did we have before this?
Sure. So the first step when you're making a score is, does the score do what you want it to do, and is it reproducible? So the first study was very much about reproducibility so that's the test, retest, multiple users, all of that kind of stuff. And the second study was a kind of a corollary question, does it change over time? So we looked at the dynamic of, admission versus later on. And what we found is it seems to be highest on day one, which I think correlates to people's experience of the first day is kind of the most wild before we get them tucked in and things like that. So a lot of times you'll see that the MRC score, the prediction modeling that we do is around 24 hours, is for that reason. But of course, the whole point of this was, does this relate to patient outcomes, and does it relate to pharmacist workload? So there was another study that looked at, basically, does it relate to pharmacist interventions and drug-drug interactions? It does, via correlation. We did a small external study to see multiple institutions, did it work from that perspective? And then, the conversation that kind of kept coming up or kept getting kind of put to me when I was trying to go for different funding related to the MRC score was, well, does it work in the South and the North and out West? And does it work in the medical ICU and the surgical ICU and the neuro ICU?
Yeah.
And so that was really kind of what was lacking at that point when this study was kind of being put together. And so I was interested in trying to figure out how to put this study together. And so at the time, there was also a big interest in basically cost avoidance and what are pharmacists doing. And so I became connected with the study team that's associated with PharmCrit and was like, wow, you guys basically have done all this incredible infrastructure. And all we would need to do is kind of add the MRC score and some outcomes, and we would really be in a beautiful spot. So the things that were leading up to this was, does it work in other places, in other ICUs, and does it really relate to the outcomes like mortality and length of stay, as well as interventions in this kind of larger setup?
Well, let's get to the featured article, our trial of the week. So a 2022, and it's a critical care medicine article, right? So just published last year in September, and entitled "The Impact of Pharmacists to Improve Patient Care in the Critically Ill, a large multi-center analysis using meaningful metrics with the MRC-ICU score." So one kind of note was, if you're pulling this article, if you're looking at it, this was a study that was endorsed by the FCCM Discovery Network and a work product of the FCCM CPP, or the Clinical Pharmacy and Pharmacology section. So definitely want to shout out, if you pull up the Appendix 1, all the authors and their institutions are listed. Lots of FCCM members, lots of friends of the pod, and familiar names that are contributing this awesome stuff. So definitely wanted to shout out, right? If you look, quick glance, it looks like there's 38 people, right? So this is a huge testament to just the amount of manpower and the research team behind the MRC-ICU.
Yeah, I think that's something I really want to, I actually have it highlighted in yellow as the only note that I want to talk about really from this study. Everything we're going to talk about with this study was possible because of infrastructure, through being involved with a national organization, through an incredible core study team that really put together everything that was PharmCrit. And I think that that's really worth noting. But then on top of that, not only is there the 38 authors, but then if you go and look at another supplemental, you'll see another huge list of all the different people that collected data to make this happen. So while I feel that today I can be a spokesperson for this paper, there is no way that a large, impactful study like this happens without really a national effort, a team effort, and a really thoughtful, coordinated effort. And I really think this is something we need to be thinking of going forward for the profession. So thank you for pointing that out.
Yeah, 100%. A great and necessary plug. I completely agree. Now, this was like we pointed out, multi-center. Now, it's an observational study collecting data from August 2018 through January 2019. So we've mentioned the PharmCrit study, and so it was using data from those patients, right? Now, that is a 2021 critical care exploration study demonstrating that pharmacists significantly reduced healthcare costs and the cost avoidance on a per dollar basis. For every dollar spent, the savings is somewhere between $3 and $9, right? So everyone listening should have already known all the great things, but it's always great when you're able to see it published in the patients that we're actually treating, right? So we're using that data, and the data was retrospectively collected through that to then capture patient outcomes and the MRC-ICU scores. Now, this study had two primary aims: to evaluate the MRC-ICU relationship to patient outcomes, number one, and then evaluate the relationship of the MRC-ICU to pharmacist workload. Because like you mentioned, just having a high Apache or SOAP score sometimes doesn't necessarily capture all that you have to do work-wise or just in patient care responsibilities with those kinds of patients.
Correct.
So data from 65 critical care pharmacists, 28 institutions, and over 3,900 patients being cared for. So that is just, wow, awesome data. Huge kudos to everybody involved. It's most commonly from academic institutions, and then the most common ICU was a medical ICU in terms of like the practice site. So, Andrea, fill in any gaps, and then talk about what this study ultimately found in its results.
Sure. So, I think it's, again, I want to highlight this kind of dual primary outcomes. So I think anytime we're looking at a score that is supposed to be capturing what a pharmacist does, I think we would dislike if we found that there was no relationship to patient-centered outcomes, to mortality, to length of stay. And I think that also is really important from where are we going as a profession. So as a profession, we're thinking that we want to be valued for our cognitive services. We want to be valued for bringing about a culture of evidence-based medication use. And so we're about the patient. So it needs to be related to a patient-centered outcome. And I think that moves us away from the so-called widget counting that you hear about. So I do think that was really important. But again, as you said, a high Apache score and pharmacist workload are not necessarily one-to-one. And so that was another kind of really important component of what, how are we looking at what a pharmacist does. And so within there, we had two different things. So we had pharmacist interventions. And, interventions people can get cranky with. It's widget counting. It doesn't necessarily capture all the things that I was doing. What happens if I did an intervention every day, but then I make a protocol and now I don't do that intervention anymore? Those are some of the limitations, right? So I want to acknowledge that up front, that is one of the limitations. But one of the ways we tried to work around that within workload was to create an intensity score of those interventions. And so different interventions were weighted as higher intensity versus lower intensity. So if you're making, high-level decisions on broad-spectrum antibiotics, that has a higher score than you're making kind of a simple IV to PO switch on famotidine. And it's not that the famotidine isn't important, but they are different. So I think that those are kind of some key things to realize. So I think the really important things to take away from this is that we did some univariate and some multivariate analysis. And when we looked at mortality, for every kind of 1 point increase in the MRC score, your odds ratio went up by 9% for your odds of mortality. And that's in an unadjusted analysis. And when it was adjusted, it went up for every 1 point, you went up 7% increase in your mortality odds. And, I think what's interesting is that number kind of plays out in different other studies and different other kind of like preliminary analyses that we look at. And I do like that. So one drug potentially is related to a 7 to 9% increase in mortality. And I found that to be a pretty fascinating number to take a look at. With regard to length of stay, we also saw that every time that the 1 point MRC increase, you also saw an increase in the length of stay. So it took about like 4 points up to get a full change in one day length of stay. But I think that's, again, pretty significant. Vancomycin plus insulin potentially, is causing an increase in that stay. Not causing, is associated with. And then when we got into interventions, we did see that for every point increase, there was an increase in interventions as well as intensity of interventions. This relationship was a little bit weaker than we had hoped to see. So if you're not using beta coefficients as often, so when you look at these kind of like 0.02 increases, what does that mean? So you would need a fair amount increase, like a full point MRC to see, multiple points MRC to see one change in intervention. And I don't know if I don't want to get too much into the discussion early, but I think one of the things that we see with this is reporting can be difficult. So was there good reporting in this? So I think that is always a limitation. As much as I think the pharmacists did a great job, I think on the busier days you can struggle with this. I also think that one thing to realize is we don't necessarily have patient acuity data in here, and I think that is an important confounder that we didn't collect in this study. So I think it's important that the relationship is there and that we could see it in this multi-center fashion, but we might not have had quite the sample size for the degree of heterogeneity that we were looking at, hence the slightly weaker signal.
Well, I mean, I guess to play the other side, right? You're pointing out the limitations of interventions, right? If there was a perfect score or things to capture that, I guess we would all be using it, right? And how many of us, right? It's limitations, but it's one of those where it's unfortunately the hand that we have right now, and we're obviously exploring and trying to find new things. But I would argue that that's most of the time how you're able to capture these things. I think that's appropriate limitations you brought up. I hadn't even thought about the protocol one, to be honest with you. But I just want to defend the MRC investigator, MRC-ICU team for a little bit. I appreciate it. Now, I guess where do we go with this positive data from here? Because I know we were looking at how it affected pharmacist workload and outcomes, but this is in line with the positive things of a lot of those smaller studies. So how will this ultimately try to what's your thoughts of how this might ultimately make our lives better in the ICU?
So I want to talk about two things with regard to that.
Yep.
One of the other things that we took a look at that was very interesting. So with regard to the MRC score, and an interesting finding was that we noticed that when the patients when you took care of more patients, you had a higher pharmacist to patient ratio, is how I think about a ratio like that we noticed that there was reduced number of interventions, reduced intensity of those interventions, and also a longer length of stay. And so again, this is association, so we cannot necessarily say this, but there is an interesting story to be had here that when we increase the workload of a pharmacist, you do worse quality care, and that has an impact on a patient-centered outcome. And to me, that was a really exciting thing that I think we all know is true. I think we know when we take care of 50 patients versus 20, it's not as good of a day. And we know, and I think it's satisfying to see that there probably is an impact on patient-centered outcomes. And I feel like that was a really important signal that we saw, and it's probably one of the most important takeaways from this study is pharmacist workload matters with outcomes. And so if you have not heard about the Optum study, that is really looking at this. To me, Optum is a direct offshoot from this study.
Put a plug for the Optum study. Hopefully the listeners are familiar with it, but let them give us a quick kind of blurb as to what that is for those who are unfamiliar.
Yes. So the Optum study is, I got to give a shout out to Kelly Keith, Susan Smith, and Moshe Hebner, who have been kind of my core team for this, who we are trying to create a multi-center prospective study connecting pharmacist workload to patient-centered outcomes, to mortality, to length of stay, and with a really rigorous design. So we're looking for 30,000 patients in order to be able to take into account ICU type, first day of ICU stay, patient acuity data, all the things, so that we can have a definitive link. And I think we're going to have some really rigorous statistical methods, some machine learning methods within that, and really try to help define what the critical care pharmacist practice model should look like. So I'm incredibly excited with that. But I think that study was a direct offshoot of this. And I think that's incredibly important to take away, that signal is there. And interestingly, to me, where MRC score fits in Optum is that it's a covariate. It's a covariate in the model. Just like you would have age or sex or Apache score, you would have an MRC score in there to say, okay, this really is important, even regardless of different degrees of medication regimen complexity, the pharmacist workload really does matter. So anyway, I think that is kind of a fascinating direction for this. The other thing that I think I took from this is that the MRC, well, maybe two other things. The MRC score shows to me that medications are important. And while you'd say, duh, I'm a pharmacist, of course I know this. If you go look at a mortality prediction study, you go pull up how we look at mortality prediction, length of stay, drugs aren't in there. We don't, and somehow we're blind to the important role of medication. And so I think if you're ever having someone say, what does a pharmacist do? You can say we manage the meds, and the meds are really important. They're related to mortality. And I think, and although that sounds obvious, in speaking with basically NIH study sections and people from the Joint Commission and all of these things, this is actually a relatively novel concept at times in a kind of a shocking way. The other thing that I really would love to see is for more implementation studies. I really would like to see how people are using it. We implemented the MRC score. We got data over the course of a month or a quarter, and we're going to look at our workload in association to that. And we're going to use that as an objective marker, as opposed to basically what we do now, which is what one pharmacist is like, dang, I'm pretty busy. Like, I should probably go talk to someone, right? Like, and it's not that that doesn't work, but I think that there is a lot to a meaningful metric, a metric you can take to your C-suite and say, please look at this. This matters.
I don't think this is going to offend anybody. We as pharmacists aren't good at asking for help. We just aren't. By the time by the time you have gone and asked for help, right, you have probably reached your breaking point, and that's why you're finally doing it. So that's the only thing of like, by the time we're actually trying to get help, right, it's almost like, adding the second pressor when your norepinephrine is at 1.5 mics per kilo per minute, right? And it's like, we probably missed our window, right? So that's, I like that you brought that up. What's the process if you wanted to incorporate this tool, like you mentioned the hospital in Oregon? Is there a process or anything for how you could implement this tool into like your local hospital or health system, like EHR?
Yeah. So what's wonderful about OHSU is that they have Epic, and so they built it within Epic coding. And Epic, you can share code. So if you have an Epic system, all you would need to do is you could email me, you could email anyone at Oregon Health Sciences. I actually had a group that took this and built it at Children's Hospital of Atlanta to do some pediatric assessments. So it's built there. So it's open source. You're welcome to go build it yourself. But I think there's two ways to think about this. One is, of course, electronic data pull and electronic build is obviously the most efficient in the long run to be able to do ongoing quality improvement, to use it as part of your workflow. And I think there's a lot to be said for that. But I also think if you were like, I just really would like a baseline assessment, as tough as maybe a manual chart pool is, or electronic chart pool and adding it up, I do think that for a 1 week, I'm going to get an average for all our different ICUs. I think that could be a valuable data point for a conversation that you're having at a local level about physician justification and things like that. But I would love to see it as more part of a electronic health system or health record, just as you might have SOFA or Apache.
All of us non-Epic institutions listening just got a little bit sad there for a second. I don't think that there's a perfect health record I think there's pros and cons to all of them, but the customization and things is certainly a drawback. Okay, let's doom and gloom is over. So what's the future plans for, you find this, how can either other future research studies incorporate these results, or how are you all, the MRC-ICU investigator team, looking to build off these results? Go any way you want.
Yeah. So I think, this is if I could get on my soapbox, this would be a call for any listener who is thinking about a workload study or workload optimization. I think the MRC tool is an important part of your repertoire for characterizing the workload within your unit and having conversations about physician justification. And to me, that's a paper that's been waiting to happen, which is someone says, I've got 6 ICUs. We ran numbers on these different metrics, including the MRC. We looked at our numbers and we made these changes to workload, or we think this is where we need to go. I think that is a paper that people need to see, and I would love to see happen. Of course, there's just so many hours in the day. So if you're asking why it hasn't happened, it's just, unfortunately, there's only so many hours in the day, as much as I love talking and thinking about the MRC score. So I think that's one, I would say for any listener, I think that's a really valuable thing. And I really think anytime you're thinking about pharmacists, implementation type studies, any of that, I think the MRC can be valuable as an additional metric. Some of the work that I'm associated with that my team is doing that's funded through AHRQ has to do more with prediction modeling. So this is stuff where you're using machine learning as well as traditional regression, and you're looking at what predictors are the most important. And I think one of the things that is just really fascinating right now is we did some different things with fluid overload, with mechanical ventilation, and it shows up in the machine learning as a top feature, as something that's really important for how the model is built, that medications and the MRC score are important. So I feel like if you're interested in ICU prediction modeling, this potentially has a place within those concepts. Trying to think of what else. I think those are probably my 2 biggest ones at present.
Yeah, and if you're wondering, right, at Andrea Sikora. If you're like, you know what, I'm just going to reach out to Nick and he can pass it along, I can definitely do that. But I completely agree. That's an appropriate soapbox. Now you're talking about people kind of trying to do more research with it. Can pharmacists still join that MRC-ICU investigator team? Are applications still open? Is that what's the, or has the ship left the dock?
No, there's always room on the team for someone who's interested in advancing the profession. So in this case, for the MRC investigator team, what was really important about this study and all of the things that went into this was not only was there this core, group that you see in bold on the paper that was, keep organizing the IRB and keeping everyone in line, but there were all the actual data collectors that were helping with this. But then because of FCCM's policy about having a multi-professional authorship team, I was connected in with different physicians, dietitians that were part of this team. And so it's actually really neat is that Ashley DePriest, as dietitian, is really interested in that workload from her perspective, which is really cool. David Murphy is part of my AHRQ team and has been an absolutely lovely mentor who's had lots of things on this. But there's a lot of people that have along the way have really participated, and I wanted to kind of honor that. Honor that very much so. But if anyone's interested in the MRC team, you can at me there, or I even have a website that you can click from there that you can go and you can read all the MRC pubs to your heart's delight. You can email me from there. But the reason I try to be that accessible is because I think this work is really important and has really important ramifications for our profession going forward. My other soapbox, I'm sure you guys have done a journal club at some point about vitamin C and sepsis, and we go back and forth on whether that study and this and that and the other, right? And yet, there's a meta-analysis on pharmacists on rounds, and we're associated with a 22% reduction in the odds of mortality. Tell me one medication decision you made today that has that type of impact, compared to getting a pharmacist on a rounding team. And I think that's really important for us to consider.
When you play that game of trying to find like multiple studies that show a medication induced reduction in mortality, gets really dicey. Plug away and federally funded researcher, right, that I said in the beginning. For those who don't know, that's what AHRQ is, right? The Agency for Healthcare Research and Quality. So the big boys think this is important, and we agree. What awesome research that the whole team, everyone involved has done. Glad we got to highlight just a little piece of it. At Andrea Sikora, Pay It Forward, A Map to Mentorship in Medicine. Get that book at Amazon. It's unbelievable. Everyone's looking for like ideas, right? You just had an awesome preceptor, right? Or things like that, right? This is a really cool kind of gift idea. Andrea, thanks for coming back. It had been way too long. The only thing I got to say, you mentioned vitamin C. Normally it's $1 fine. Your first one's free, but the next time vitamin C is on, it's going to be, you're going to get a Venmo request for $1. I'm just warning you. Okay.
Okay. That's honestly very fair.
Thanks again, Andrea. We appreciate you.
Thank you.
Another huge thanks to Andrea. She's the best. Let us know your thoughts, right? Andrea at Andrea Sikora, at PharmacyToDose, PharmacyToDose at gmail.com if you want to send me an email. Reminder, right? Website's getting a little spring cleaning. I guess you'd say fall, summer cleaning. So hang tight. You'll still be able to access the reference list and some of the media that gets hosted on that. You just won't be able to actually go to PharmacyToDose.com just yet. So big week, right? 4 pods in 4 days. So hopefully everyone enjoys. Reach out. Let me know what you think. But until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast. The Critical Care PRN is dedicated to fostering the role of critical care pharmacists as essential members of the multidisciplinary patient care team. The Critical Care PRN's goal is to optimize drug therapy outcomes by promoting excellence and innovation in clinical pharmacy practice, research, and education. For more information, including how to become a member, go to critprn.accp.com. Again, that website is critprn.accp.com. The podcast provides general information only, does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. Use of the contents and materials on the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users and patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guests and should not be interpreted to reflect the official position or policy of ACCP or the Critical Care PRN. ACCP and the Critical Care PRN disclaim any and all liability or responsibility for any direct, indirect, incidental, special, consequential, or any other damages, including without limitation, loss of profits arising out of any use of, reference to, reliance on, or inability to use the podcast, its contents, and materials.